Dear colleagues, this is a soft cataract done in subconjunctival anesthesia. The pupil is not very well dilated. It's a shallow anterior chamber. Place some trypan blue to stain the capsule, and under the viscoelastic I use the Grisauer forces to make a nice 5.5 millimeter capsular axis. It's very easy thing to do with this versatile forceps. Then using a hydrodissection cannula, decompress the bag a little bit and push some BSS to do hydrodissection. Try to rotate a little bit the nucleus. The patient is helping me a little bit by moving his head. Enlarging one of the paracenteses and start the phacoemulsification. In this case I use the stop and chop technique, cleaning up the anterior cortex and then making a trench and using the chopper to break that nucleus into two. It's a very soft cataract, soft nucleus, but I'm able to crack it and have two separate heminucleus parts, and then rotating the phacoemulsification bevel towards one heminucleus. I'm able to tease it out of the bag, do a small chop and break that heminucleus into smaller pieces and basically aspirate it, since it's a very soft cataract. It's a bad cornea. As you can see, I have the pterygium, which makes the visualization a little bit challenging. But the cataract is going well, very nicely. One half of the nucleus is out and the other half I'm teasing it out, moving it from one side to the other to place it in front of the phaco needle and slowly aspirate that. That's the soft other half of the nucleus, and then using the phaco needle into the cortical aspiration program. I'm aspirating this heavy, thick layer of epinucleus slowly to not catch accidentally the posterior capsule, and trying to bring it and aspirate it as much as possible using the phaco probe. I like to use two instruments inside the eye when I do this aspiration by the phaco needle. It's stabilizing the globe a little bit, especially in these cases where the patient is not so cooperative in moving the head around. Slowly, this procedure takes more patience than anything else. Especially this part of cortical aspiration by the phaco needle needs to be patient and take your time, not rush to this step. And then for the last part, underneath the main incision, I use the irrigation through the main port with an AC maintainer and using the aspiration cannula, finishing up the cortical aspiration, hydroimplanting the IOL inside the bag under AC maintainer, and then we'll use crescent blade to take out the pterygium also. I prefer to take out the pterygium at the end of the phacoemulsification if I have a bigger portion of the cornea to see the cataract, to remove it, because it's very bleeding and I don't want that blood to obstruct the view during phacoemulsification. Incising, cleaning up the limbus area, and I like just to cut the head of the pterygium with a scissor and do a subconjunctival injection with dexamethasone and gentamicin. That's the end of the case. Thank you for your attention. Hope this will help you in your practice also.